Hi, everyone, and welcome to the Parkinson's Foundation Greater Illinois Chapter Let's Talk About It program. My name is Jessica Barch, and I'm the Community Program Manager of the Greater Illinois Chapter. I want to welcome all of you for joining our program tonight. We're so happy to put these programs on for you and to also bring this important information to the Parkinson community. Before I start my programs, I typically talk about our great resources. And today I really want to highlight our PD fact sheets. So the fact sheets look like this. They're basically 1 or 2 pagers, and we have a fact sheet library online that you can access and download these PDFs. So all of these are free, and they really talk about almost every topic related to Parkinson's. And the 2 that I will highlight today are a fact sheet that's called urinary dysfunction and Parkinson's, and also constipation and other gastrointestinal problems with Parkinson's disease. I also want to point out our wonderful publications. So we have great books that deal with motor and non-motor symptoms of Parkinson's disease. And these books are really a great way to educate yourself and to also help you become your best advocate for yourself. Something that's very important to point out is our Aware and Care kit. So this kit is something you bring to a hospital setting with you, and really it has everything you need inside of it to communicate with your healthcare team about the importance of getting your medication on time. Last but not least, we have a wonderful helpline that is staffed by Parkinson's specialists. That number is 1-800-4PD-INFO. It's a great place to start if you're newly diagnosed or if you just have any questions and need guidance. So something I'm really excited about tonight is that we are going to start our program with a movement. So we always like to emphasize movement and how important it is for Parkinson's disease. And this movement is a gentle stretch. It's a yoga stretch. So I invited my colleague, Krista Ellis, who is a certified yoga instructor, and she is going to show you how to do a stretch that aids in digestion and will help you really cope with maybe those problems or those challenges of constipation. So please interact and do these stretches at home, and we really hope that they're helpful. And then after that, we'll move on to our main presenter. So thank you again, everyone, for joining us, and I'd like to welcome Krista Ellis.
Hello, everyone. I'm Krista Ellis. I'm a certified yoga teacher, and I am joining you today to offer you a yoga practice that will help aid digestion and constipation. I want to thank Jessica for inviting me to share this beautiful practice with you all today during this event. So, how does yoga aid digestion or constipation? So the yoga postures, in yoga we call these asanas, these poses, these movements, asanas. They stimulate different areas of the body, different organs, different body systems. And we'll be focusing our movement today on stimulating and activating the organs of the abdominal and digestive area. And so we'll be doing some forward folding, some twisting that will help relieve and improve the digestive system and constipation. Yoga also improves blood circulation. So as the blood flows freely and improves, it makes all the body systems more efficient. So let's get started. I'm sitting in a chair with no wheels. So I'll strongly encourage you to find a chair today that doesn't have any wheels. We don't want to go for a ride. And I've also chosen a chair that doesn't have any arms. So a chair without arms gives us a little more freedom to move around in the space. Of course, the arms can feel very supportive. So if you have a chair with arms, please feel free to use that chair. So we want to start in our most comfortable seat. We call this Sukhasana pose. So bring the feet flat onto the floor. Sit bones are nice and grounded down into the seat of the chair. And then you want to lift up out of the belly, find length through the spine. Good. Looking down at the toes, moving the heels out a little bit to bring the ankles underneath the knees. And once you feel comfortable in your seat, gently closing the eyes, just taking a moment to check in and to notice how your body feels today. Deep breath in and a breath out. And softly fluttering the eyes open. Hello. We'll take both hands out by the sides. Inhale, reach the arms up. As you exhale, place the right hand down. Inhale, reach the left fingertips up and over, finding space in the left side body. Breathe. Next, inhale, sweep both arms up, centered over the hips. As you exhale, left hand comes down to the chair. Reach the right fingertips up and over. Side body stretch. Breathing in and breathing out. Use your next inhale to sweep both arms up. And exhale, float the arms down. Good. Hands meet the legs. Drag the shoulders up, back and down. Good. Coming into a forward fold twist. So you're going to sweep that right arm up. And as you exhale, reach for the left toe, left ankle, left shin. Use an inhale, sweep the left arm up, twisting open towards the left. Good, breath in. And as you exhale, we'll bring that left hand now over towards the right shin, right ankle, right toes. Use an inhale to sweep the right arm up and over, twisting towards the right. And your exhale brings that right hand towards the left leg. One more each side. Inhale, sweep the left arm up. Exhale, sweep the left arm down. Inhale, right arm reaches up, twist open. Exhale, right comes down. Good. Staying in our forward fold, uncrossing the arms and letting the top half of the body hang over the legs. Hands can come to the ground, to the feet, ankles, shins, or maybe they rest on the knees, whatever feels comfortable in your body. And notice if you're trying to hold the head up. I'm not going anywhere. See if you can let the head relax down. So as we sit here in our forward fold, you might notice some pressure on the belly and the digestive organs. This pressure can be really relieving to any aches or tension that constipation or digestive discomfort might be causing you. Take another breath here. And let the breath go. Then slowly begin to lift the body up, either by pushing the hands into the knees. We'll bring the torso centered over the hips. Good. Take any wiggles that might feel necessary here. And our last pose always makes me chuckle because the name of it's actually called wind releasing pose. So just be curious as to what you feel in the body when we come into this asana, this posture or this pose. So you begin by lifting the right foot up off of the ground. You can interlace the fingers on the top of that right knee. Start to hug that right knee in towards the chest. Good. Letting the foot float here, or if it feels accessible, you can plant the right heel onto the chair, really hugging that knee in towards the chest. Good. So just an option. If it feels more comfortable in your body to let the foot float, then let that float. If you have the heel up onto the chair, choosing to stay active in the spine, or maybe rounding over that right leg, maybe bringing the knee to the chest and hugging the knee in towards your body. Again, applying some gentle pressure to the abdomen to help relieve and move things along. Good. One more breath wherever you are. And exhale, softly plant the right foot down. Good. And we'll gently lift the left foot up, interlacing the fingers at the top of the knee. And begin pulling that left knee in towards the chest. Maybe you can bring that left heel to the end of the chair. Or maybe you stay with the foot floating. Your body, your yoga. Whatever variation you did on the other side, I'll invite you to take it on this side as well. If you had the heel on the chair, maybe wrapping the arms around the leg and hugging the knee in. And wherever you're at, take a deep breath. And stay for the exhale. Good, inhale. And as you exhale, softly let that left foot come down to the ground. You take those wiggles that might be moving around in the body. Take the arms out by the side. Inhale, sweep the arms up. Exhale, float the arms down. And just as we started, we'll plant the hands onto the tops of the thighs or the knees. And gently close the eyes. Just take a few moments and notice how you feel right now. Maybe bring a smile to your lips. And when you feel ready, gently fluttering the eyes open. So I hope that you found some of these poses helpful, or at the very least intriguing and motivating you to try yoga again. And I want to thank Jessica for inviting me to share this practice with all of you. If you have any questions, Jessica can get you guys in touch with me. And I wish you all to have a very, very good rest of the event. Thank you.
And now it is my pleasure to introduce Dr. Abhi Mahajan. Dr. Mahajan is an assistant professor of neurology at Rush University Medical Center in Chicago. He specializes in the care of patients with Parkinson's disease and other movement disorders. After medical school, he received a master's in epidemiology from the Johns Hopkins School of Public Health. During this time, he also conducted research in aging and non-motor aspects of Parkinson's disease. He completed his neurology residency in Detroit at Henry Ford Hospital and a 2-year fellowship in movement disorders at the University of Cincinnati. His research has been funded by the Parkinson's Foundation, the Sunflower Foundation, and the Dystonia Medical Research Foundation. His research and clinical interests lie in non-motor aspects of Parkinson's disease, including pelvic floor health, sleep, and cognition. He also sees patients in the new Rush Multidisciplinary PD-GI Clinic. Welcome, Dr. Mahajan. We're so happy to have you join us today.
Hi, Jessica. Thank you so much for that kind introduction. It's a pleasure to be here. It's an honor and a privilege. And thank you so much to everybody who's taking time out of their evenings to come and talk about a topic that we hear about often in clinic, but not often enough. It's a topic that affects a lot of patients with Parkinson's, affects their quality of life, and has treatments, but it often goes underappreciated or not talked about because of either shame, stigma, or just lack of awareness. And my goal at the end of this talk is for us to know a little bit more about this topic so we know what to bring up and what to keep an eye out on when you go and see your neurologist for Parkinson's disease. Here are my disclosures. As Jessica said, my research has been funded by the Parkinson's Foundation, Sunflower Parkinson's Disease Foundation, and the DMRF, but I have no conflicts of interest. I will be talking about some management strategies that are not FDA approved, but I'll get to it. We'll talk about it when I get to that slide. So, what is pelvic floor health? For this specific talk, we're going to be talking about constipation. We're going to be talking about incontinence and how that sums into pelvic floor health. So pelvic floor dysfunction is basically an umbrella term for a broad constellation of symptoms. The underlying commonality between all of these symptoms is that it relates to the anatomy and structure of your pelvic floor musculature or muscles. Amongst all the different clinical manifestations of pelvic floor dysfunction, the one that are really relevant to us and to this talk are those related to urination and to bowel movements. Throughout this talk, I'm going to be using words like pooping and peeing just for ease of conversation, because I feel like that's the first thing that we need to get over. If we don't bring it up, we don't talk about it, we can't address it, and we can't improve our own quality of lives. So we're going to be talking about difficulty in urination, including hesitancy, delay in urinary stream. We're going to be spending some time talking about urinary incontinence and the types of urinary incontinence as well. But the majority of this presentation is going to be spent talking about constipation and gastrointestinal issues and how they relate to not only Parkinson's disease, but also the medications that we take to improve symptoms in Parkinson's disease. So let's start with the official definition of what is constipation. We don't need to read through this entire verbose definition, but what it basically says is that constipation is unsatisfactory bowel movement. And it's characterized by either A, you have infrequent stools, second, you have difficulty in the stool passage, or both. Now, what constitutes as difficulty in stool passage? Well, it may include A, straining, a sense of difficulty passing stool. After you're done with a bowel movement, you may feel like you haven't had a complete bowel movement. The poop that you may have may be hard or lumpy, or it may just take you a long time to pass stool. When any of this or a combination of any of these happen for more than 3 months, we call it chronic constipation. We'll just skip this slide for now. So how common is constipation? Well, you just saw how many different things are grouped under the umbrella of constipation. And because of that, by definition, constipation may range from 8% up to 70% in Parkinson's disease. Think about that. Symptoms of constipation may happen in 7 out of 10 patients with Parkinson's disease. If we go by the most commonly used criteria for diagnosis of constipation, that is, if you have a frequency of less than 3 bowel movements per week, about 50% of all patients with Parkinson's have constipation. The most common constipation-related symptom is straining to have a bowel movement. Now, another thing to note is that constipation is not just associated with Parkinson's disease, but it's also associated with the medications we use to treat Parkinson's disease. More on that later, but basically, patients who take dopamine agonists such as ropinirole or pramipexole may have higher incidence of constipation compared to those who take carbidopa, levodopa, also known as Sinemet. In later stages of the disease, as the disease progresses, constipation may be due to not just the disease, but a combination of the disease and escalating dose of treatment. Now, why should we care about constipation? Yes, it's common, it's highly non-specific, right? Most of us feel that if we eat steak or if we eat a meal with a lot of protein, we do get some constipation. So why does it matter in Parkinson's disease? Well, it turns out it's one of the first non-motor symptoms to develop during the prodromal phase of Parkinson's disease. It may precede motor symptoms such as tremor, stiffness, slowness by years. A study which looked at constipation in patients with diagnosed Parkinson's disease found that the odds of developing Parkinson's disease once you have constipation was over 2 times. Now, because of all of this, constipation has been recently included as a research criteria for prodromal PD as one of the risk factors for future development of PD. How does it affect our quality of life? Well, it's important to note the various aspects of Parkinson's disease that may be associated with a higher risk of having constipation. So Parkinson's disease with constipation more often develop Parkinson's disease later in life, have a longer disease duration, more advanced disease, and may have other signs of more advanced disease, such as poorer sleep quality, severer or more severe autonomic symptoms, let's just assume that is a word, fatigue and apathy. Accordingly, greater age and more advanced stage of Parkinson's disease, depression, anxiety, autonomic dysfunction increases the risk of constipation in Parkinson's disease patients. Multiple studies have shown, and you don't need studies for us to even know this, that constipation exerts serious impact on the activities of daily living or your ability to do things that you would otherwise have no problems doing in Parkinson's disease. A brief line on why we think constipation is a prodromal symptom of Parkinson's disease. How does it fit? It doesn't make sense. Parkinson's disease is in the brain, right? So why should constipation, which is clearly in our gut, why should that be an important factor in Parkinson's disease? Well, it turns out it is. Dr. Ali Keshavarzian, who's the head of gastroenterology at Rush University, has been one of the pioneers in research on gut in Parkinson's disease. And according to him, so all of us without Parkinson's, let's say people without Parkinson's disease have gut flora. We have some microbiome, some microbes, some bacteria that reside in our gut. What happens in Parkinson's disease is there is some pro-inflammatory factors, or there's some inflammation that leads to that composition of bacteria getting messed up. And because of that, that can lead to protein misfolding and then development of Parkinson's disease. And this may happen up to 20 years before you actually have motor symptoms and you get diagnosed. And this is the prevailing theory. This is something that's been actively looked at, that is being actively studied, both here at Rush and at multiple centers across the world. But this is the theory that in Parkinson's disease, your composition of gut flora or gut bacteria is compromised. And because of that, that leads to misfolding of proteins and then development of Parkinson's disease. There are some studies that indicate that Parkinson's disease may even start in the gut. But again, take this with a pinch of salt because these are just hypotheses that have not been proven so far. Now I'm going to skip all the way from pathophysiology and talking about prodromal factors of Parkinson's disease and things like that to how do you manage constipation in Parkinson's disease. This is a recipe called Rancho recipe, which we often give to our patients here. This is not FDA approved. There is no study done on this, but you will notice that most of the ingredients that are used in this recipe are things that you can get from a grocery store over the counter. And our patients report that they do notice an improvement with this. So this is not FDA approved. This is just something that we see in our clinic, and we see it providing clinical benefit in our clinic. We often recommend, I'm going to just leave it up there for you to read, but it basically involves bran, prune juice, applesauce. You can stir it into oatmeal or just eat plain. What other options do we have? Well, there's always the probiotic yogurt with prune flavor, thought to be the best for management of constipation. It can be taken with bran flakes, fresh fruits like berries. You can take it, you can eat it daily as a snack or daily for breakfast. It's all about making a habit of eating healthy, eating foods that are more easy to digest and help other food move faster through your gut. More of that later. There are, of course, medications that we prescribe in patients who do not get any benefit from such recipes. Miralax comes over the counter. A lot of you might have tried it. It's one of our first medications that we do prescribe for moving the gut along. Senna or Dulcolax are other medications that we prescribe. Some of these we don't prescribe on a long-term basis, maybe for short bursts to get the gut moving. But basics are important. Before we even think about medications, think about the basics. You just had a 10-minute excellent session on yoga that helps with digestion. Well, it turns out exercise in general does help with digestion. Basics such as drinking enough water. If you're adequately hydrated, you will avoid constipation in the first place, and you don't need to be prescribed medications. If you're thirsty, you're already dehydrated. So do not wait to become thirsty to drink water. Also, keep in mind that caffeinated beverages like coffee, soda, tea will further dehydrate you. So if you're drinking caffeine, drink even more water. So what happens, what are the other advice, tips, or just suggestions that we have in patients with Parkinson's disease, which are non-pharmacotherapeutic? What else can we do? Well, in Parkinson's disease or in constipation in general, like we said, the physical strain of having a bowel movement may be very difficult and painful. Sitting in a squatting position can help relax certain muscles and make the passage of bowel movements or passage of stool much easier. One helpful tool to help with this is Squatty Potty. I don't know if you've heard about this. It's available on Amazon, Bed Bath & Beyond. It's an inexpensive stool. You just it fits around the base of your toilet. You can rest your feet on it and naturally adopt that posture that makes passing stools a lot easier. Here's another anti-constipation paste recipe. I'm just going to leave it up on the screen for about 10 seconds for everybody to just read this. This is, again, made of ingredients that are easily available over the counter in your grocery stores. Maybe they may be in your kitchen, and you never thought of them as a do-it-yourself constipation paste recipe, but they're highly effective, at least early on in the disease. What are some of the other medications with some evidence? Well, you have macrogol or polyethylene glycol. Salem is another one. In some patients, rarely, there's the option of injecting botulinum toxin. As you know, or you may know, botulinum toxin is a toxin that helps relax muscles. So the muscles around the anorectal juncture or the anus, painful as it sounds, it's extremely beneficial in some patients. So that's always an option, but that's an option that we keep towards the end when all other options have been exhausted. There are other medications that gastroenterologists usually prescribe, such as cisapride or tegaserod, and these have also been found to be helpful in small research studies. Like with everything, there is an app for that. So believe it or not, there are apps available on your iPhone, like Poop Tracker, like PCAL. These apps help you record information about how frequently you have a bowel movement, how long were you sitting on the pot, what was the shape of the bowel movement, whether it was lumpy, whether there was any diarrhea, all the uncomfortable questions that you never want to think about or mention. You document those in this app, and at the end of the month, it gives you nice figures and tells you how have you been doing, whether you've been getting better, getting worse. And this kind of information is incredibly helpful for your primary care physician, your neurologist, your gastroenterologist, and something for you to know. This is just a summary slide. I just kept it there because I wanted you to have a good idea about all the options in terms of treatment that we currently have and those that are under investigation. And this slide is from 2016. There are even more things that are available. The bottom line is we have all these methods and strategies to help constipation and indirectly help your quality of life in Parkinson's disease. But there is no way for us to even try any of these unless you bring it up to your neurologist or your primary care physician, or if you have a gastroenterologist, that this is something that's bothering you. Now, we spoke about constipation. We've spoken about how it's non-specific, but it seems like it's an important prodromal factor in Parkinson's disease. We even dove deep into what could be the potential pathophysiology behind it, what are the management strategies for constipation. But let's talk about something that's as important, if not more. What about your GI tract? How does that affect the medications that you're taking to replace the dopamine that's low in Parkinson's disease? Well, first of all, levodopa carbidopa or Sinemet is still the most effective therapeutic agent to manage symptoms in Parkinson's disease, your motor symptoms. In an ideal world, before we have Parkinson's disease, our brains are basically submerged or swimming in dopamine. And so you might think that it might be easier to just maybe get an IV or an IM injection with levodopa. Unfortunately, those options are not available. And the reason for that is you would need really very large volumes of daily injections to kind of match the dopamine that you already get from an appropriately dosed pill regimen. Now, the good thing is, even though Parkinson's disease is a progressive disorder, and of course, when you see one patient with Parkinson's disease, you see one patient with Parkinson's disease. Everybody is different. All of our disease is different. The response to medication is different, and progression is different. The good news is the way levodopa carbidopa is absorbed within your body is not affected by progression of Parkinson's disease. However, levodopa itself does affect how quickly you're able to poop. So it affects your ability to empty your GI tract. And therefore, that explains why in some patients, the absorption of levodopa might be erratic. Now, something more about diet and effectiveness of levodopa carbidopa. Most of it is absorbed in the proximal part of the small intestine. What that means is you have your stomach, then you have your small intestine, your large intestine, your rectum, and then poop comes out. So right after your stomach, the next part is the small intestine. And that's where most of the absorption of levodopa happens. The most important factor in how effective levodopa is how fast food moves through your stomach all the way out of your body. So the rate of emptying of your GI tract is the most important factor in how effective or how much your levodopa gets absorbed. And therefore, it's important what you eat, because what you eat often dictates how fast that food gets out of your body. So if you eat a lot of fat, it may take much longer for that food to get out of your body. Therefore, one recommendation that I often make to patients is that you should have you know how you have your time when you take your levodopa 3 times or 4 times or 5 times a day. Whatever your dose is, whatever your regimen is, it's often a good idea to start levodopa or take levodopa about half an hour before your meal or an hour after your meal if you don't have any side effects. If you do have side effects, taking it with meals actually helps blunt those side effects. But it's often a good idea to take it, on an empty stomach for it to just go through your gut and get absorbed much easier. Of course, if you have side effects, you have spoken with your neurologist, by all means, please do not change your regimen based on this. What are the other factors? Well, if you have a lot of acidity, a lot of GERD, that may reduce levodopa absorption. If you have low iron and you're taking iron supplements, that may reduce levodopa absorption. Another thing is if you're eating a lot of protein, that may reverse the therapeutic effect without actually reducing the levodopa concentration. What that means is that if you're eating a lot of protein, that may affect how effective levodopa is. And on the other end of the spectrum, if you eat a diet rich in insoluble fiber, it seems to improve levodopa absorption and therefore how effective levodopa is. I just put this slide in there because this is a very hot topic of research. In clinic, we often hear about it. Microbiome. Can different patients with Parkinson's disease have different microbiomes? Just by looking at microbiome is basically the composition of bacteria in your gut. All of us have some composition of bacteria in our gut, and that thing is specific to you. Therefore, it's called a microbiome signature. So everybody has their own microbiome signature. Now, can that microbiome signature be different in patients with Parkinson's disease or patients without Parkinson's disease? And even in different types of Parkinsonism, is it different in multiple system atrophy, or PSP, different types of Parkinsonism? The answer to that question is there is some recent literature that suggests that that might be the case, but we still don't know enough. And we definitely don't know enough to target that to improve motor symptoms in Parkinson's. And it happens to be a topic of very high interest. And I suspect in the next 5 years, a way to target precision medicine in Parkinson's disease based on your microbiome or gut flora. What is SIBO? SIBO is another term that you may have heard or read online, small intestinal bacterial overgrowth. So what happens is certain bacteria there might be an overabundance of certain bacteria in your gut, and that may actually adversely affect or reduce the absorption of levodopa in the small intestine. And therefore, in some of our patients, we do send them to gastroenterology to get them tested for SIBO. And in Parkinson's disease, because constipation is so common, and because using PPIs, what are PPIs? Omeprazole or pantoprazole, things that help you with GERD, is relatively high, and that may be associated with SIBO. Let's talk about this bacteria called H. pylori. I don't know if you've heard about this. It's been pretty widely covered in the news recently, at least the news that I've been watching, where there's a question about, well, you're a patient with Parkinson's disease, you take your levodopa, carbidopa, it seems to work at some point, and some days it doesn't seem to work. Is it because you have this bacteria growing in your gut? Well, this question has been with us for close to 20 years now. In 2001, there was a study on just 17 patients with Parkinson's, where they found that after they give antibiotics to kind of eliminate H. pylori, this bacteria, patients with Parkinson's disease had higher levels of levodopa in their blood, thereby suggesting that before, when H. pylori was there, it was affecting the availability of this drug in the blood. But since then, there have been other studies, including one on 34 patients, that said, well, that's not true. There's really no difference. Despite that, there have been many papers, there have been many editorials that have suggested that H. pylori still might play an important role in drug absorption. Well, thankfully, due to a study that was recently published a couple of months ago in Movement Disorders on 310 patients with H. pylori, what we found is all those fancy graphs. Basically, what they say is, one, treatment of H. pylori does not improve your motor symptoms in Parkinson's disease. And therefore, if you're not having a consistent response to levodopa, carbidopa, there is absolutely no justification for screening for H. pylori or just giving you antibiotics to eradicate that bacteria. That does not make any difference to how effective your levodopa is. Lastly, what is irritable bowel syndrome? Now, if you haven't heard about irritable bowel syndrome, it's basically loosely these three things. One, your bowel, your gut, it feels like you need to use the restroom. You have this urge to have a bowel movement. Second, you have a bowel movement and you notice an improvement in how good you feel. You may have a change in how frequently you use the restroom or how frequently you have bowel movements, and the way your poop looks might also change. So this is called irritable bowel syndrome. It is exactly what it is. It's an irritable bowel that feels better once you poop. It's also known as functional gut disorder, or within the same umbrella. It's found in almost a fifth of patients with Parkinson's disease. There's been a question about, like with constipation, does it increase risk of Parkinson's disease? My personal opinion is it does not. And the reason I have a personal opinion is because there haven't been enough studies to demonstrate that it does. There's nothing in science right now to say that it increases the risk of Parkinson's disease. Is it still widely prevalent in Parkinson's disease? Yes, it is. 17% of patients with Parkinson's disease have it. So whenever you have something like this, please bring it up to your primary care physician, to your neurologist, to your gastroenterologist. You'll undergo a detailed assessment by gastroenterology. There's a diet for it called FODMAP. which basically gives you a list of foods that are irritable for your gut and foods that are gentler on your gut. And that list is available online as well. Any kind of stress makes it worse. And then there's treatment by way of medications as well. So if this is something that's bothering you, please bring it up, because there are management strategies for this. And this is my turn to shamelessly plug our clinic. I'm rather proud of this. This is from what we know, the first of its kind in the entire world. It's a PD-GI clinic that we just started at Rush. I mentioned Dr. Keshavarzian, who's the head of GI here and world-renowned leader in gastroenterological issues in Parkinson's disease. I see patients here. Our division head, Dr. Deborah Hall, also sees patients in this clinic. If this is something that concerns you, if you want to be seen in this clinic, I'm just leaving this number on the stage. And I'm sorry, on the slide set, I'm going to leave it here for a second for you to note and call during working hours to make an appointment. All right, so moving from pooping to peeing. That's a nice segue. Why did I keep this slide on as the first slide? Well, this is because it's often thought of that issues with urination or peeing cannot be related to the brain. That could not be further from the truth. Pretty much everything that we do in our body is to some extent controlled by the brain. All these nice colors that you see here, all of these parts of your brain are involved in urination. In addition, your spinal cord is also associated with urination. In Parkinson's disease, we all know the chemical that's low in the brain is dopamine. When you have a reduction in dopamine, it leads to a decrease in control of your bladder. So you may feel the urge to go faster. There's a condition called overactive bladder that I'll talk about soon. In a broader context, it's very similar to irritable bowel syndrome, because you have this sense, you get this feeling that you need to use the restroom often than you need to, and then there is a sense of relief after you use it. So what is overactive bladder? Well, urgency is central to diagnosing overactive bladder. You have this urgency of going to the bathroom. You have this sudden compelling desire to pass urine. If you try to hold it, you won't be able to, or it's very difficult to. This may happen in the daytime, so you may have increased urgency, greater frequency of urination. You may not be able to make it to the bathroom on time, and we'll talk about those. That's called incontinence, and there are a multitude of various types of incontinence. But basically, you have this urgency to use the bathroom. You may not be able to make it on time, and this may wake you up at night, which is very commonly seen in Parkinson's disease. A lot of our patients wake up in the middle of the night to use the restroom. Of course, we have to keep in mind that BPH is also common in this age group as well. And so is urinary tract infection. More on that later. So what kinds of urinary troubles are seen in patients with Parkinson's disease? Well, there is high prevalence of urinary urgency and frequency. Like I said, it's very common. We are unable to delay urination, and therefore it's even more important in patients with Parkinson's disease, because there's a difficulty in getting from point A to point B. Slowness, stiffness, tremor, all of these make it difficult to go from one place to the other. And because of urination, you have this urgency to get to point B, it makes it even more difficult in Parkinson's disease. And therefore, overactive bladder has been associated with worse quality of life, something we call autonomic dysfunction. Also, cognitive impairment or thinking and memory issues. And as you may imagine, if you try to go from point A to point B and you're unable to because of Parkinson's disease, especially in the middle of the night, it may lead to falls as well. So how common is overactive bladder, urinary incontinence, urinary urgency, basically urinary issues in Parkinson's disease? It's very common, and it's associated with increasing age. and associated with dementia or difficulty with thinking and memory in Parkinson's disease. How widespread? We don't know. And the reason for that is, again, because of the spectrum of features that get grouped under this, and also because this is not something that's commonly brought up. But we think it's anywhere between a quarter of patients to everybody in Parkinson's disease eventually develops some kind of issue with urination. Even outside of Parkinson's disease, almost half of all women in Parkinson's in the United States, more than 80 years older than 80 years of age, report at least one of the symptoms that I mentioned to their physicians. So that's how how widespread it is. Now, I'd recently mentioned that there are different types of incontinence. The most common types are stress incontinence and urgency incontinence. So what does that mean? Stress does not mean psychological stress. Stress means physiological stress, or stress on your bladder. What that means is if you cough, if you sneeze, there's a chance of a jet of urine escaping without you having any voluntary control over it. Urge incontinence or urgency incontinence means just that. There's an urge to pass urine and you're not able to control it in time. And then there are patients, there are people who have both. That's called mixed incontinence. I put this slide up there for us to appreciate that some of these happen with age, irrespective of whether or not you have Parkinson's disease. And that would be mostly around the most common age group for Parkinson's disease is, you would say, between 60 to 80 years of age, maybe. And during that age, urgency incontinence seems to increase irrespective of Parkinson's disease. So because we don't know how common these issues are, pelvic floor issues in Parkinson's disease, especially in women with Parkinson's disease, and whether it's just a question of us getting older, or is it because of Parkinson's disease, we conducted this study. This was done at University of Cincinnati and University of Louisville, Kentucky. So done in collaboration with our colleagues in GYN, gynecology, in geriatric medicine and neurology. We used questionnaires to survey women with Parkinson's disease. And we also looked at women without Parkinson's disease, but of the same age. And we asked them questions about their pelvic floor health. We looked at how bad the motor symptoms of Parkinson's disease were and how much of an issue they had with thinking and memory. The entire idea behind the study was we need to find out how much Parkinson's disease contributes to these issues with incontinence versus it's just a question of getting old or older. Well, what we found was these fancy graphs your figures that you're looking at. Basically, what we found was that women with Parkinson's disease do have worse pelvic health than people of the same age group, women of the same age group without Parkinson's disease. But there was no difference in reporting of these symptoms and seeking specialty care. Let me say that again. Women with Parkinson's disease have worse symptoms of urinary incontinence and constipation than people without Parkinson's disease of the same age group, but were as likely to seek help. Therefore, it's safe to say that these pelvic floor disorders are undertreated, underappreciated, undermanaged in women with Parkinson's disease. This is another study, which is a little old now, that we did. We looked at all people, we looked at a sample of all patients with Parkinson's disease that got admitted to the hospital over 10 years across the entire country. And what we found was that urinary tract infection was going up as a reason why people with Parkinson's disease got admitted. As a general rule in my practice, Parkinson's disease is not an unpredictable disease. So as a general rule in my practice, if somebody calls me and says, well, Dr. Mahajan, a couple of days ago, I was doing really well. And then this morning, or yesterday morning, I just woke up and I feel like I'm very slow, very stiff, I'm confused, my husband, my wife, my spouse, my friend, they're very confused and they seem like they're much slower. How did their Parkinson's get so bad? my first instinct is to always, always check for any infection, any metabolic change, or any drug change that would have caused this. As soon as we identify, and urinary tract infections or UTIs are very common in Parkinson's disease. As soon as we identify that there is an infection and we treat it, within a week or so, you'll find yourself getting back to how you were before infection started. Something for us to know. I just kept this slide there for us, me included. I'm not a urogynecologist. I'm not a urologist. Most of this I read in medical school, which was a while ago. But just for us to know that there are so many different kinds of incontinence. We discussed the two most common kinds, but there is really there are many different kinds of incontinence. And I'm very cognizant of the fact that this is not my area of expertise, but often patients with Parkinson's disease do not mention this, and therefore, if we don't know, we won't be able to refer you to people who do know how to evaluate these and how to treat them, because there are treatments available. So how will these people? How do experts evaluate these? Well, obviously through history, there's a physical examination. They will look at how severe your symptoms are. They discuss what your goals for treatment are. The same as we evaluate you for Parkinson's disease. Everybody more or less gets, in our population gets checked for urinary tract infection. Another thing which is important in Parkinson's disease to know is because the muscles that control urination or peeing are then again muscles, right? So they are affected in Parkinson's disease. So it's not uncommon for urine to just sit there in your bladder without you knowing that it's there. And as we know, standing urine can be ripe for infections. And that's why urinary tract infections are so common in Parkinson's disease. And so people who are experts in this, urologists, urogynecologists, often use all of these to assess, you in clinic. Other fancy things they use all of this as urodynamic testing to measure different aspects of how much urine you're storing, how easily you're able to pee, and they use all of this. I don't pretend to understand or know any of this. My wife is a urogynecologist, so I know about this more than I want to, but I should, because these are things that are very common in Parkinson's disease. What treatment options do we have for urinary incontinence? Well, they vary by what kind of incontinence you have, how bad the incontinence is, and what are your goals of treatment. They range from pelvic floor exercises to injections to medications, and there are surgical options. There are slings and things of that nature. And all of this depends on, again, what kind of incontinence you have, how bad, how severe your incontinence is, and what the goal of treatment is. And all of these treatments exist. We just need to know to seek them out. And again, I sound like a broken, broken drum here, but we won't know to refer you to experts till we find out. So make sure that you keep a list of these things and mention it to your primary care physician or neurologist. Believe it or not, there's also deep brain stimulation for urinary incontinence. It's not something that we do often at all, but it's there. And I just wanted you to be aware of this. For those who don't know, deep brain stimulation is a surgical modality. It's a procedure that we do fairly frequently at Rush and at other centers, of course, for managing motor symptoms in Parkinson's disease, but even for urinary incontinence. Remember the first slide, control of urination is also in the brain. So deep brain stimulation can be effective as a last resort. It can be effective in improving your ability to urinate, frequency, urgency, incontinence. Urination at nighttime is the hardest to treat, but female Parkinson's disease patients do end up doing better than males. I just wanted to keep it out there, put it out there. With that, I thank you for your interest, and I'm going to stop rambling now. Thank you so much.
Thank you so much, Dr. Mahajan. Just making sure that, okay, good. You can hear me, I'm unmuted.
Yeah.
No, I appreciate that great presentation, because these are topics that we want to bring to light, and We know how much they do affect quality of life for people with Parkinson's. And I love that you kept reiterating that the importance of actually telling your doctor, telling your movement disorder specialist, telling your neurologist, because nothing can be treated unless you disclose that information. So, so thank you for sharing that. We really always appreciate, you know, our experts' time. So thank you.
Absolutely.
So just give me one moment because I am going to, I just wanted to, before we go on to our Q&A segment, I just want to take a brief moment here to talk about our wonderful sponsors. So, and I also want to remind all of you, please use that Q&A little box on the bottom, the black banner on the bottom of your page, because that is where we can access all the questions and everything that you want to ask Dr. Mahajan. So before we move on to the Q&A, like I said, I do want to thank our sponsors for today's program: Lundbeck, Kiowa Kirin, Synovian, Supernus, Accorda, and UCB. Their support really helps us keep today's programs and all others free and available to all. So a real big thank you to our wonderful sponsors today. In addition, for more information about these companies and the resources that they offer the PD community, including detailed product information, please visit our virtual exhibit hall. This is a little picture of what that looks like. It's located at this link, parkinson.org/Greater Illinois/chapter-supporters. And when you visit this page, all you need to do is go to that sponsor's logo and click on it, and it'll bring you to all that information. All right, so now we are going to do our Q&A. So I'm going to take some questions that, just give me a moment here to. I just have to access my document here so I can see the questions. There's always some little blips with technology, so excuse me, everyone. Okay. So, so doctor, I know, and some of these will kind of be reiterating some of the things that you had said, but I think this is a lot of information for people to take in, and it's real great information. And also, I just want to say to our attendees right now that you'll receive, in about a week or so, you'll receive a follow-up email with the links to a recording of this program, links to the slides, and any resources that we're discussing, we will include in that follow-up email as well. So please don't feel like, you have to write down all this stuff. We will share this information with you afterward. So just know that. So here's my first question. Someone had said, I am not on medication currently, and I wonder if I start taking it, will it help my bowel movements?
Well, I would say for any personal, medication recommendations, you should see your neurologist. Without, it's impossible for me to say what would work in your case specifically, but I can do say that in our patients with Parkinson's disease, often taking dopamine does help them to a certain extent with constipation as well. Constipation is a complicated. So your bowel movements are a complicated system overall. It's not just your muscles. So I'm going to take one step back and answer this that way. The thing that's low in Parkinson's disease is this chemical called dopamine. Amongst other things, the most important chemical is dopamine. The purpose of dopamine is to help with movement of muscles. Even when you think you want to move your hand and bring it closer to the camera, even that thought is mediated by dopamine. So fluidity of movement, coordination between muscles, all of that is dopamine's role. And that coordination holds true for your entire GI tract, including your small intestine and getting poop out, all of that. So dopamine does help with that. Along with the muscular part of things, you also have something called the autonomic system, which is affected in Parkinson's disease. And so both of these systems work together to make sure that you have good, solid bowel movements. When somebody with Parkinson's disease does take any kind of dopamine replacement, including Cinemet or levodopa, carbidopa, you can expect some improvement in constipation. I hope that answers your question.
Thank you. Thank you, doctor. Does a decrease in dopamine result in a weakness in diaphragm muscles, resulting in weaker bowel movements, resulting in constipation?
So the diaphragm is not involved in your bowel movements at all. So diaphragm, I think I understand the question. Just to get this out of the way, diaphragm is also a muscle. It may be affected in Parkinson's disease, but diaphragm is the muscle you think of when you hiccup. For example, that's one muscle that you think of. It can be involved with difficulty in breathing and so on and so forth. But yes, muscles that are involved in getting food from the point that when you place food in your mouth, all the way to swallowing, all the way down through your GI tract to the point when it leaves your body, all of that is done by muscles. And the coordination of those muscles to some extent is mediated by dopamine. And therefore, when you do take medication to replace the dopamine that is low in Parkinson's disease, you do see an improvement in coordination of these muscles, and therefore an improvement in ease of digestion and having bowel movements.
Great, thank you. Could there be tremors that could tremors be causing frequent voiding? I can stop my tremor by thinking of stopping it, but it's hard to control the voiding.
No, so I'm not sure I understand the question entirely.
I'm wondering if the attendee is wondering if their tremors are causing them to go to the bathroom more often.
I would say no. But having said that, difficulty in having a bowel movement, if you may remember, I mentioned that straining to have a bowel movement is the most common form of constipation seen in Parkinson's disease, a manifestation of constipation in Parkinson's disease. So that straining and the tremor, both of them are because of Parkinson's disease. So you may think of low dopamine or Parkinson's disease at the top, and you have the tremor here, and you have constipation. Both of these are clinical manifestations of Parkinson's disease, but tremor does not cause constipation or the other way around.
Okay, thank you. So are there any research studies you're aware of that focus on incontinence and PD going on right now?
We don't have any research studies on incontinence in Parkinson's disease happening right now. I can tell you that it's a very hot topic right now. I'll have to look and see if other centers are doing it. I know that urinary incontinence in neurodegenerative disorders, including Alzheimer's and Parkinson's disease, is a topic that's been talked about a lot in urogyn circles, or not in neurology, but not only in neurology, but in gynecology. But I'm not aware of any specific studies at the top of my head that are happening. There are no studies that are actively happening in incontinence at Rush right now, but watch the space for more, because that's something that I'm really interested in, and we're going to make a move on that soon.
That's great. I've heard eating smaller meals throughout the day can help with constipation. Is this true?
Yes. The idea is that your belly doesn't get overwhelmed with too much food. Having said that, it's also important what kind of food you eat throughout the day. I love steak, so if I eat steak multiple times a day, it's unlikely to help constipation, because that's a lot of protein. So if you're eating the right kind of food, which is insoluble fiber, you're more likely to help constipation. It matters more what you eat than how you eat it. But yes, smaller frequent meals are better for your gut and getting poop out than large meals with a lot of fat, a lot of protein.
Okay. That makes sense. So are there problems if someone is using stool softener long-term?
Depends on the stool softener and depends on how long. So things like Miralax, we are more comfortable with people taking Miralax for a long time. We have some patients who've been on it for a while. Things like Dalcolax, they have a shelf life. And if somebody has that severe constipation that they need to be on something daily for a period of time, we most definitely seek help of our colleagues in gastroenterology, because they are the ones who deal with constipation with Parkinson's disease, without Parkinson's disease. We need to remember that constipation is very common even outside of Parkinson's disease. So whenever any of our patients need something on a daily basis for a prolonged period of time, we do seek help from our colleagues in GI. But yeah, Miralax, I'm less worried about something like Miralax compared to Dulcolax, but then again, depends on the patient.
Okay, thank you. My loved one with PD is sedentary and also has constipation. Can forced exercise help with this? For example, we have a pedal machine that he uses occasionally.
So I'm glad you asked this question. I'm always glad when somebody talks about exercise. We have so many good medications to help symptoms in Parkinson's disease: levodopa, carbidopa, the dopamine agonists. We have pumps. We have deep brain stimulation. We've become really good at managing symptoms in Parkinson's disease for the most part. What we still haven't been able to do is slow down Parkinson's disease. It's something that we get up every morning, all excited about research, all excited about our patients. But after 27 plus trials, we haven't been able to do it so far. The only thing that we know that has consistently been shown to slow down Parkinson's disease or the pathophysiology behind Parkinson's disease is exercise. It doesn't even matter what kind of exercise. As long as you're exercising 4 times a week, and everybody's threshold is different, you exercise 4 times a week, you're doing yourself a huge favor and making your neurologist look good in the process. Obviously, there are a couple of things that make exercise difficult in Parkinson's disease. One is something we call apathy, which is very common in Parkinson's disease. That could be another talk in itself, but apathy is basically your will to do things goes down in Parkinson's disease. And therefore, if I have Parkinson's disease and I have apathy, I just don't feel like exercising. And that's where the question of forced exercise, I completely appreciate where you're coming from using forced exercise. And then the other part, of course, is that if your symptoms are not well managed, if you're slow and stiff, it is hard to do exercise even if you want to. But if there's a stationary bike, I really like stationary bikes. Again, swimming, stationary bikes, running, whatever's best for you works. But stationary bikes are good because it takes into account the fact that your balance might not be perfect. And that's absolutely fine with stationary bikes. As long as you're using it 4 times a week to the point where you're exerting yourself a little bit 4 times a week, you're golden. And that will help not only improve symptoms, but also slow down Parkinson's disease. At least that's what all studies have shown us.
So basically any exercise, even this forced with the pedaler, is beneficial and can help with constipation. So that's great. So this question, and again, this, this is something, of course, we've talked about through the whole program, but I like this question. It says, please provide a simple, concise explanation for why these 2 conditions are a result of my Parkinson's, so I can help my family understand.
Which 2 conditions? Constipation and incontinence?
Yes.
So the simple explanation is both of them are affected by lack of dopamine, which is the central chemical that's low in Parkinson's disease. And both of them are to do with the structure and function of your pelvic floor. Your pelvic floor includes the muscles that help you to poop and the muscles that help you to pee. Both of them happen in your pelvic floor. So both constipation and incontinence are affected when you have difficulty in your pelvic floor, and both of them are affected when you have low dopamine. And therefore, in Parkinson's disease, both constipation and incontinence are very common.
Okay, thank you.
I hope that was simple, but that is the simplest way of explaining this. And I have to say, I'm not an expert in pelvic floor health either. I like to think of myself as an expert in Parkinson's disease, but Parkinson's disease has many different facets, as we've as you've discussed on this series and as we've discussed today. But that is the simplest explanation for why both these things can happen in patients with Parkinson's disease.
Thank you. As a woman with Parkinson's and some incontinence issues, how important is it to identify urogynecologist who is affiliated with a Parkinson disease movement program compared to one who is not?
More than a urogynecologist that's affiliated with, I mean, obviously, if you can identify a urogynecologist at a good center with a strong Parkinson's disease program and they talk to each other, nothing like it. What is even more important than that is to identify a urogynecologist who's aware of these issues in Parkinson's disease. Therefore, they are aware of what happens when somebody is undertreated for Parkinson's disease, overtreated for Parkinson's disease, and what to expect in women, or I mean, for urologists for men, urogynecologists for women with Parkinson's disease. I would say that is important.
Okay, thank you. Is there any impact on the person with Parkinson's if they are using oxybutynin?
Oxybutynin is a medication that's often prescribed for urinary incontinence, just to set the stage. It does help with frequent urination. A lot of patients report improvement in the number of times they get up in the middle of the night to pee with oxybutynin. So it is an effective drug. Unfortunately, we do see that oxybutynin also contributes to confusion in our patients with Parkinson's disease. So if you come to my clinic and if a patient in my clinic comes to me and says, well, I've been confused lately, I'm not myself, it's taking me longer to answer questions or I forget things, and oxybutynin is one of the medications that's listed, that's taken for urinary incontinence, I often have a discussion with their urologist, urogynecologist, primary care physician to see if there is a possibility to change it to another medication. There are other medications like mirbetriq that might be better. Of course, it's not as simple as that, right? It's possible that everything comes with risks and benefits. And I'm just giving you an example for something that I've seen in my clinic, where I've requested the urologist to change the medication from oxybutynin to another one, which unfortunately, we did a trial of another medication instead of oxybutynin that had been very effective, and the other medicine wasn't as effective. And that may lead to increased urination in the middle of the night. And that affected the patient's quality of life a lot more than mild confusion did. So there's a lot of nuance here that's often trial and error, and there's a lot of teasing out what things matter more. But oxybutynin, while it may be very effective for urinary incontinence, may cause confusion in patients with Parkinson's disease. That is the bottom line.
Okay, thank you. So there is a gentleman that was asking about, and I don't know if I'm going to pronounce this correctly. He was saying, could this medication called entacapone possibly be causing constipation? Is that?
Entacapone is a medication for Parkinson's disease. The end goal is still the same, to increase dopamine in the brain. Unfortunately, like I said in one of my slides, later on in the disease, constipation is thought to be caused because of mixture of both the disease and as a potential side effect of the medicine, the combination of them both. So it can be one of the reasons why you have constipation. It can be, yes, especially later on in the disease. But then again, we end up making sometimes these difficult decisions on reducing a dose of a medication that's likely helping patients from a motor standpoint, but often have constipation as a side effect. So it's often risk versus benefits. But yes, to answer your question, especially later on in the disease, it can be a factor.
It can be a factor. Okay.
Yeah.
So this has to do with the recipe that you had up. It says, what kind of bran goes into the first recipe? Flakes, wheat, oat, other, what form?
I believe all kinds of bran will work, but let me see if I can pull up my slide deck and keep that recipe. I see that there was, I cheated and I just looked at one of these questions and it actually mentioned looking at the recipe. So let me see if I can pull up my recipe. This recipe again. Is it okay if I do that?
Yes, you can. And this will be the last question that we're ending with. So please go ahead, pull that recipe.
Can you see? All right, let's see.
I could see the notes too, but
you can.
Yes, but that's okay. You can just get to that.
Well, I wish I had some notes, which I don't. Now it should be better. Let's see. So this is one of the recipes, the anti-constipation paste recipe.
You know what? We are not seeing it right now. We are seeing diet and effectiveness of levodopa.
It says, how about now?
There. Oh, there we go. There it is.
So this is one of the recipes. So I'm going to keep this one up. And you
And
said
it is smaller right now, just to let you know, but we will be sending all of these in a, we'll be sending these recipes also in a follow-up email so people can have clear, concise instructions. So let me see. Doctor, I wonder if you can make it just a little bigger. And if you can't, then that is okay, because we're seeing the kind of the note on the side and not just the screen view.
Oh, you're not seeing the screen?
We're seeing, sorry, I apologize. We're not seeing the slideshow view is what I'm saying. So it's, you know what I mean? We're seeing two slides basically next to each other.
Oh boy, I'm so sorry about this.
No, it's okay. And you know what, actually, again, like we will include this. So, and we could also get, Dr. Mahajan, we can also get clarification from you if there is a question about that recipe. We can actually put that in the email as well. So.
Yeah, this is, I just put it up. Can you see this one? This one's
Yes,
probably
yes.
easier to read.
1 cup of bran, 1 cup of prune juice. So I bet you it could be any type of bran. It just sounds like it's something that's high fiber, something that'll help with that. So perfect.
But
well,
again, great. Please feel free to use this recipe if you must, but please bring it up to your neurologist as well. Make sure that they know about this.
I mean, really the ongoing theme is communication.
Yes, absolutely.
Yes. So, well, I think that'll conclude our Q&A segment. You know, and Doctor, I can't thank you enough for sharing again this really invaluable information with our Parkinson community. It means a lot to us, and we know that our attendees appreciate it, and you know, we greatly appreciate it. So thank you very much.
Absolutely.
Well, and everyone, we will be ending our program right now, and we're so happy that everyone joined us today. We really enjoy bringing these programs to you, and we think that we know that they're important, helpful topics, and getting some practical solutions, especially to these issues that can affect quality of life. So before we go, I just want to let you know of another upcoming program that we have on November 14th. It's called On the Menu, Nutrition and Parkinson's Disease. It's from 11:30 a.m. Central to 1 p.m. Central, and that is the link to register. Again, all of this will be included in a follow-up email. So parkinson.org/IL nutrition. And always our website for up-to-date information about Parkinson's disease, parkinson.org is our website. So much information on there. And also the wonderful specialists at our helpline, 1-800-4PD-INFO. Always a great place to start if you have any questions and need some guidance. So again, everyone, we thank all of you for joining us today and for spending this time with us. So we hope you all stay well and healthy and safe. Thank you.